What I'll be talking about today is cystic lung diseases in general, with a specific focus on three that are most likely to be seen or asked about on the boards. Um, I have no conflicts of interest. So there are many cystic lung diseases. Some of them you will hear about in other talks that today or tomorrow. And others you probably will never see. What I want to talk about today are the three or four here at the bottom: lymphangioliomyomatosis, Langerhans cell histiocytosis, Birt-Hogg-Dubé syndrome, and lymphoid interstitial pneumonia. LIP, or lymphoid interstitial pneumonia, will probably be covered in the talks about connective tissue disease and interstitial lung disease. It's a form of cystic lung disease that occurs in conjunction with connective tissue disease such as Sjogren or lupus. So the bulk of the talk will be about the other three diseases. What's in common between these three diseases is they're all caused by mutations in a tumor suppressant. And whether it's a systemic mutation or a mutation that specifically affects certain cells of the body, we'll talk about that, but they all consistently are caused by mutations in tumor suppressant genes. So the first disease that I'm going to talk about is lymphangioliomyomatosis, or for short, LAM. As you can see from this CT scan cut, that LAM is a cystic lung disease, and the nature of the cyst is they're round, surrounded by a thin wall, and they don't have any specific geographic distribution. They could be anywhere in the lung from top to bottom. No predilection for the outside or the inside of the lung. And it's a disease that affects almost exclusively women. So if you have a woman with cystic lung disease, LAM has to be in the differential diagnosis. So beyond the cyst that you can find in the lung, LAM is also characterized by the presence of chylous effusions. So this is a very large chylous effusion that you see here on the chest X-ray. And this is the type of fluid that you can see in milky, largely consisting of triglycerides and cholesterol that you can see from draining these lipid-filled pleural spaces. In addition, LAM can be seen either sporadically, where you just have the lung disease with associated chylous effusion, for example, or it could be part of a broader complex called the tuberous sclerosis complex. And it's important to screen for the tuberous sclerosis complex when you see a patient with LAM, simply because the implications for the patient and their families could be very significant, especially that the tuberous sclerosis complex can be inherited. Sporadic LAM cannot be transmitted to the children, but tuberous sclerosis complex can. So it's important to ask about personal and family history of tuberous sclerosis, personal and family history of seizures, developmental delay, whether or not there are some skin lesions that can be consistent with tuberous sclerosis, whether or not there's bilateral kidney tumors called angiomyolipomas or AML, and whether or not there's a history of brain lesions. So in the next slide, you'll see the battery of different manifestations of TSC. So as you can see here, this is LAM. This is a big kidney tumor, and angiomyolipoma, as the name indicates, is formed of angio, blood vessel, myo, muscle, and lipid-filled tumors. Sometimes there's very little lipid, but with the MRI, you can detect that. There's also these brain tumors that are called SEGAs. There's skin lesions, like here, a café au lait lesion, nail lesions, and obviously you can see the rash here on the face as well, and there's also retinal lesions. So whether LAM occurs in conjunction with the tuberous sclerosis complex or with as a sporadic LAM, the manifestations are give or take about the same. And this is a close-up of the angiomyolipoma that you can see both in sporadic or in tuberous sclerosis LAM. Now, pneumothorax is obviously a life-threatening complication that can happen in women with LAM. it can happen at in about 60% of the patients, and about 40% of the patients present with a pneumothorax. So if you have a woman who's acutely short of breath, who has cystic lung disease and has a pneumothorax, then you also have to be thinking about LAM. Now, once you get a pneumothorax, if you have LAM, the chance of recurrence is incredibly elevated at about 70%. So it has to be dealt with relatively aggressively with pleurodesis, because the risk, again, of the pneumothorax and a fatal pneumothorax can be pretty high at about 70%. So LAM is also one of the rare lung diseases that we actually have a biomarker for. So there's a blood test that allows you to diagnose LAM. Vascular endothelial growth factor D, VEGF-D, not just VEGF, which is VEGF-A, is diagnostic of LAM if the levels are above 800 picogram per ml. So if you have a woman with cystic lung disease and a VEGF-D level higher than 800 picogram per ml, then this is diagnostic of LAM. VEGF-D is high in about 2/3 of women with LAM, so not every patient with LAM will have a high VEGF-D, but if it is high, then it's virtually diagnostic of LAM. So in essence, what we're talking about here, if you have cystic lung disease on a CT scan, thin wall cyst, diffuse top to bottom of the lung with any of the following: a kidney tumor called angiomyolipoma, a chylous effusion, VEGF-D level greater than 800 picogram per ml, or a history of tuberous sclerosis complex, then you don't need a biopsy. This patient has lymphangioliomyomatosis, and there's no need to biopsy the lung. In the rare cases where you need to biopsy the lung, what you'll see on these biopsies is this is a cyst. You'll see in the wall of these cysts the LAM cells or the LAM nodules, and this is a close-up of these lesions. You can see these elongated, look like fibroblast lesions, and there's very specific markers that allow the diagnosis. For example, HMB45, which is a melanoma marker. But in this day and age, very few women progress to requiring a surgical lung biopsy. Now, LAM is caused by mutations in the tuberous sclerosis complex 1 or tuberous sclerosis complex 2 genes. And the pathway downstream of TSC1 and TSC2 is very well known. It involves the mechanistic target of rapamycin, so the mTOR complex. And we know that we have actually a very good drug that actually blocks mTOR, and it's called sirolimus or rapamycin. And rapamycin has been in clinical use for quite some time now for kidney transplant. So there was a clinical trial that randomized women with LAM to either rapamycin on the top here or to placebo. And as you can see, women who have received rapamycin had a stable lung function compared to those who received placebo and had a decline in lung function. Once the drug was stopped, both groups who were on sirolimus or on placebo continued to decline. So once a patient requires rapamycin, then there's a need for continued use of mTOR inhibition, rapamycin, or its cousin, everolimus, obviously for a long time. At this point, we have no idea when it will be feasible or plausible to stop mTOR inhibition in women with LAM. So in a nutshell, women, usually young, in their reproductive years, who have cystic lung disease, who have a chylous effusion, an angiomyolipoma, a VEGF-D level that is high, a personal or a family history of tuberous sclerosis complex is virtually diagnostic of LAM. The treatment for LAM is an mTOR inhibitor, typically rapamycin or sirolimus. So moving on, I'm going to talk about Langerhans cell histiocytosis, which is, you probably are more likely to have seen it than have seen LAM. It could be a systemic disease or a single organ disease. We don't really know the exact true prevalence of LCH in the general population. It is possible that it is as high as 3 to 5% of all diffuse lung diseases. There's no gender differences. Male and female can get LCH at equal percentages. Almost universally, all patients with LCH are smokers. More than 90% are smokers. And there's more recent evidence to suggest that it's not just tobacco smoking. There may be some correlation between LCH and smoking cannabis. But this is, again, still work in progress, trying to figure out the exact relationship between cannabis smoking and LCH. So when the disease is a multi-system disease, in addition to the cysts in the lungs, you also have a seborrheic rash, there's diabetes insipidus, and lymphadenopathies and hepatosplenomegaly in most patients. So if you have a patient who's a smoker with cystic lung disease and has diabetes insipidus, obviously LCH has to come all the way up to the top of the differential diagnosis. Now, when it's a single site involvement, it's most commonly the lungs that are involved, and almost invariably always there's a smoking history. Now, whether the disease is polyclonal or monoclonal, meaning that if the mutation is the same across all the organs that are affected by the disease, or it's a single mutation that's basically spread to the other organs, is not entirely clear. In the lung, in addition to the cystic changes, you can see small nodules, especially at the beginning stages of the disease. And most often when you do a bronchoscopy and a lavage to get cells back from the lungs, a lot of these cells, you'll get a lot of percentage of cells, typically more than 5 to 10% of cells that are CD1A positive, which is diagnostic of the disease. How these cells contribute to lung destruction is not entirely clear. And again, most of these patients will be smokers. So similar to LAM, more recently, we figured out that LCH is actually linked to mutations in a tumor suppressor. Most commonly, it's BRAF, and that has tremendous implications in how we treat the disease. Because as you may know, a lot of cancers are treated with BRAF inhibitors, the most famous being vemurafenib, which specifically targets the V600E mutation in BRAF. And it has been sporadically used in LCH with good results. It's especially effective in patients who have SIADH. Now, there's an enormous amount of work being done in trying to isolate circulating cells that have the mutations in BRAF to be able to diagnose PLCH without requiring a biopsy. In cases where it evolves to requiring a biopsy, what you'll see here, this is a lung nodule that is packed with CD1A positive cells, which again is virtually diagnostic of the disease. So what is the treatment? Nobody should smoke, but specifically if you have lung disease, you shouldn't smoke. And if you have PLCH, you should definitely not smoke, and you should definitely quit smoking, because oftentimes that's enough to lead to improvement or even resolution of the disease. So in about 40 to 50% of the cases, you'll get some improvement, if not complete improvement, with smoking cessation. In about 60% of the patients, despite smoking cessation, you can find a decline over time. And occasionally what you'll find is a decline in diffusion capacity, which is oftentimes associated with pulmonary hypertension in the context of LCH, and obviously smoking cessation. Patients with LCH, at least before the era of BRAF inhibitors, oftentimes could progress to requiring a lung transplant. I neglected to mention that in LAM, in the era of rapamycin, very, very few patients decline to require a lung transplantation. Finally, I am going to talk about Birt-Hogg-Dubé syndrome, which again is caused by a mutation in a tumor suppressor gene. It's an autosomal dominant disease caused by mutation in the folliculin gene. By about the age of 50, about 80% of the patients will have lung cysts. The degree of how many cysts could be very variable from one patient to the other. But suffice it to say, in about 80% of the cases by the age 50, you'll see some lung cysts on CT scan of the chest. Pneumothorax, there's a wide percent of the literature reported on how many patients develop pneumothorax, somewhere between 25 and 75%. And similar to LAM, if they develop a pneumothorax, the recurrence rate is very high, and it needs to be dealt with relatively aggressively. Now, what is pathognomonic of Burtag-Dubé are these skin lesions that you can find in the face, and we call them fibrofolliculoma. Excellent dermatologists have diagnosed the disease without the need of a biopsy, but these can be biopsied, and if you have fibrofolliculoma, then the patient has Burtag-Dubé syndrome. And you don't really need a genetic test. You could probably get one in order to do family genetic counseling, but for the individual patient, it's pretty clear that this is mutation in folliculin, and the patient has Burtag-Dubé disease. Now, the cysts in Burtag-Dubé, as you can see in the CT scan, can have multiple different forms. They're not just like LAM, where they're round and surrounded by a thin membrane. These cysts here that you can see, elliptoid-like shape towards the mediastinal part of the CT scan, they're virtually diagnostic of BHD. So if you find these cysts on a CT scan, more likely than not, the patient has BHD. What you'll also note is that these cysts are towards the bases of the lung, unlike LAM where they're top to bottom. These are more likely to be at the base of the lung. Now, in BHD, it is incredibly unlikely that a patient with cystic lung disease will progress sufficiently to require a lung transplant. There's usually very little progression in or decrease in lung function. So the lung cysts, although they're there, it's not really clear that they're going to contribute to life expectancy or affect the patient's life in any way other than in pneumothorax. However, what is critical is that about 25% of patients with BHD will get kidney cancer. And unlike LAM, where the kidney cancer is the angiomyolipoma, which is a benign tumor, kidney cancers associated with BHD are malignant kidney tumors. And more often than not, this is going to be what's going to affect a patient's life expectancy. So screening for kidney tumors at the time of diagnosis and moving forward periodically is essential in the care of patients with BHD. The histologic subtype of kidney tumors in BHD is varied, and you can see multiple different subtypes. And it could also be bilateral and multifocal. Finally, you can test with the folliculin gene mutation. Since this is an autosomal dominant disease, you can just test for the folliculin mutation from a blood draw, as opposed to LAM, which is when it's sporadic, only the LAM cells have the mutation. And as well as in LCH, where only the cells affected by the disease have the mutations. So it may be virtually impossible to find it in a blood draw. So finally, to recap, how do we approach this? Between these three diseases, all caused by tumor suppressant mutations, there's findings on the HRCT that could give us a hint one way or the other. In LAM, the cysts are round, they're thin-walled, they're diffuse. In LCH, they're irregular. They usually spare the angles, and you can see lung nodules. In Burtag-Dubé, the elliptical form cysts can also be diagnosed. It can give you an idea, and it's also in the lower lobes and closer to the pleura. Now, in LAM, it's almost universally women. If you see a man with LAM, you probably should be looking for the tuberous sclerosis complex, but it's incredibly unusual. Chylous effusion, the angiomyolipomas, and the VEGF-D levels greater than 800. In LCH, if you have diffuse LCH, then you have multisystem, then you can have diabetes insipidus, the skin lesions, and some bone lesions. In BHD is kidney cancer, malignant kidney tumors. The rate of pneumothorax is about the same between BHD and LAM, and in LCH about 20% as far as we can tell. And the mutations are in the tumor suppressant genes, TSC1 or TSC2 in LAM. In LCH, the mutations are in most likely in BRAF or in MEK, but most likely BRAF. And in BHD, the mutation is in the folliculin gene. All of these are tumor suppressant genes. So to move on to some questions. So question 1, 30-year-old female presenting with shortness of breath and dyspnea on exertion. The chest x-ray shows a right-sided pneumothorax. A CT scan of the chest confirms the presence of the pneumothorax and shows cystic lung disease, in addition to a fat-rich kidney tumor. The treatment is no need to be concerned about lung function. It will not decline over time. Steroids, no B, steroids, C, no available therapy, and D, it's rapamycin. All right, so I guess rapamycin is obviously the correct answer. So this woman is suffers from LAM, and the presence of the angiomyolipoma, the fat-rich kidney tumor, in addition to the cystic lung disease, is diagnostic of LAM. And LAM is treated with the mTOR inhibitor rapamycin. No need to be concerned about lung function. It will not decline. This is for Burtag-Dubé syndrome. But usually the tumors, the kidney tumors associated with BHD are not fat-rich kidney tumors. They're not angiomyolipomas. They're kidney cancer. So A would apply for BHD. B, steroids, which we occasionally use for the treatment of LCH. With little or no effect. No available therapy is actually an answer for BHD as well. There's really no therapy for Burtag-Dubé other than taking care of the underlying kidney cancer if present. And rapamycin or mTOR inhibitors is the treatment for lymphangiomyomatosis or LAM. All right, so question 2. Oh, we've been through that. Okay, so question 2 is 30-year-old female, again, presenting with shortness of breath and dyspnea on exertion. Chest radiograph shows a right-sided pneumothorax. A CT scan of the chest confirms the presence of a pneumothorax and shows cystic lung changes. A careful skin examination shows facial fibrofolliculoma. What is the next best step? Start rapamycin, steroids, lung biopsy, CT scan of the abdomen. All right, so this again is a young female, which obviously is there to throw you in for a loop. Women can still get other cystic lung diseases. And in this particular patient, the presence of the facial fibrofolliculoma is diagnostic of Burtag-Dubé syndrome. And in Birt-Hogg-Dubé, rapamycin is not indicated. Steroids are not indicated either. The lung biopsy will have very bland features. You will see dilated air spaces, you will see cysts, but there's nothing on the biopsy that will directly diagnose Birt-Hogg-Dubé. The presence of the fibrofolliculoma is diagnostic of BHD, and what you'd really need to be concerned about is the presence of kidney tumors. So the next best step, obviously, after taking care of the pneumothorax, would be to scan the abdomen looking for kidney tumors, because that invariably will decide the outcome of patients. BHD is autosomal dominant, so the gender distribution, the sex distribution is the same amongst males and females. And this is the answer. That's it. These are some references with the PMID number for additional reading if you choose to. Okay.
Suhail, thank you very much. I thought that was insightful and concise, and there were some interesting questions that I'd like to put to you, if you don't mind.
Yeah, sure. Please go ahead.
Thank you. One, just simply, what sort of pulmonary function abnormalities do you expect in LAM?
So most commonly seen pulmonary function abnormalities in LAM is similar to asthma. Obstructive lung disease, a significant percentage of patients has a bronchodilator response. So a lot of these women with LAM are initially diagnosed with asthma because their PFTs are so suggestive of asthma. In a small minority of women with LAM, about a quarter of them actually, they will have normal spirometry, normal FEV1, normal FVC, but you can find isolated declines in diffusion capacity in DLCO without the presence of pulmonary hypertension. But most commonly found abnormalities in LAM is obstructive lung disease.
Perfect. Now, what about the patients who have an angiomyolipoma discovered on imaging? Do they all need to be screened for LAM?
Not the other way around, no. So if a patient has an angiomyolipoma, you don't necessarily, it's much more common than having LAM, having an AML. So they don't necessarily all need to be screened for LAM. The reality is when you get a scan of the abdomen, you'll see the base of the lung. And usually they'll give you a hint if there's a need to continue on to get a complete CT scan of the chest.
Good. Can we ask about pregnancy and LAM? This one was, are pregnant women more susceptible to LAM? But just in general, your management, we have about a minute.
So there's reports that women with LAM are at higher risk of worsening lung function decline during pregnancy because we believe because of the increased hormonal changes during pregnancy. There are women with LAM who completed pregnancy to term without any issues. Obviously, it's a woman's decision. We will not recommend that they do not get pregnant, but if they do wish to become pregnant, it's better to do it when lung function is still normal. So even if there is a decline in lung function, then there's still a lot of reserve that to have a normal life expectancy and a normal life. More recently, in the last couple of years, there's been reports of women carrying pregnancy to term on mTOR inhibitors, although rapamycin is really a class C, so it would not be a standard recommendation at this point.
Great, thank you very much.